In 1990, the United States government took a hormone, like a hormone that the male body produces naturally just to survive, and legally classified it in the exact same category as ketamine and codeine.
Which is, it's just wild when you actually think about it.
It really is. And if you're listening to this right now, it's because you're the kind of person who questions how something like that even happens. You want the actual mechanisms behind the facts, you want to avoid all the information overload, and you're really looking for those genuine aha moments where a totally misunderstood topic finally clicks into place.
Yeah, and it's an incredible story to dig into because we are looking at a piece of the medical puzzle that is, well, it's completely buried under decades of cultural mythology. I mean, we're talking about a treatment landscape where science really took a backseat to hysteria.
Absolutely. So today's deep dive is into the wildly misunderstood world of testosterone replacement therapy, or TRT. We've got a huge stack of medical history, clinical trials, and cultural analysis to go through.
Lots of ground to cover.
Definitely. And our mission today is to separate the actual physiological science from the 1980s stigma and show you exactly how pop culture can actively derail standard medical treatment for, like, millions of people. So, okay, let's unpack this. To understand the landscape of TRT today, we really have to start right in the doctor's office. Why is getting a prescription for a basic, naturally occurring hormone so incredibly complicated?
It's the perfect place to start, honestly, because the hesitancy you see from doctors isn't just arbitrary stubbornness. I mean, to be fair to the medical community, there are layered, legitimate clinical concerns at play here.
Right, it's not just them being difficult.
Exactly. And the biggest one casts a shadow that is still felt today, which is the cardiovascular scare of 2013 to 2015.
Wait, I want to play devil's advocate here for a second. If a guy comes in with clinically low testosterone, isn't the risk of leaving him, depressed, lethargic, and potentially obese worse than a hypothetical cardiac risk? Like, why wouldn't a doctor just prescribe it to cover their bases?
Well, because in 2013, the medical journals suddenly made that risk look anything but hypothetical.
Oh, really?
Yeah. A few highly publicized studies came out suggesting that prescribing TRT might actually increase a patient's risk of heart attacks and strokes. And, if you're a physician whose primary oath is first, do no harm, a headline linking a drug to heart attacks is going to make you drop your pen instantly.
Okay, yeah, that makes sense on paper. But our sources point out that those specific studies were later completely debunked.
They were, entirely.
So how exactly does a major medical study get debunked? Like, what was actually wrong with it?
The methodological flaws were staggering. I mean, these were primarily retrospective observational studies. So meaning researchers were just looking back at massive databases of patient records to find patterns rather than conducting a controlled, forward-looking experiment.
Right, they're just mining data.
Exactly. And in doing so, they made massive errors. For example, some of these studies completely failed to measure the patient's baseline testosterone levels before deciding they were quote-unquote on testosterone therapy.
Wait, you've got to be kidding. They were tracking the effects of a hormone without checking the initial hormone levels?
They didn't even know where the patient started. And it gets worse.
Oh, man.
In some of the data sets, researchers accidentally included women in the pool of men they were analyzing for testosterone-related heart attacks.
No way. Women.
Yes, women. They also included men who were prescribed testosterone but never actually filled the prescription at the pharmacy.
So the data was just a total mess, a complete disaster.
It's a little mess.
But did the medical field ever get a definitive answer to clear this up?
Yes, but it took a decade. In 2023, we finally got a true watershed moment, which was the Traverse trial.
Okay, the Traverse trial.
Right. And unlike those flawed 2013 studies, Traverse was a massive, rigorously designed, randomized, double-blind, placebo-controlled trial. This is the gold standard. It was specifically built to look at cardiovascular safety, and it definitively proved that TRT does not increase major cardiac events.
But let me guess, the damage for 2013 was already done.
Exactly. What's fascinating here is the reality of clinical lag time. Medicine does not move at the speed of an iPhone update.
Right, it's not overnight.
Not at all. A true paradigm shift in treatment can take 20 to 30 years to fully filter from the research journals into a busy doctor's standard practice. Many doctors practicing today were trained during that scare, and that hesitancy just lingers.
Wow, 20 to 30 years.
Yeah. Plus, TRT isn't just a pill you swallow and forget about. It has a very real monitoring burden.
Right. Our notes highlight that it's a super high maintenance therapy.
Very high maintenance. If a doctor prescribes TRT, they're committing to regular ongoing blood work. They have to watch the patient's hematocrit levels.
Which is what, exactly?
It's the ratio of red blood cells to the total volume of blood. If testosterone pushes that too high, the blood gets too thick.
Like sludge.
Basically, yeah. And they also have to monitor estradiol to ensure that testosterone isn't converting into too much estrogen. And they have to track PSA levels, or prostate-specific antigen, to ensure the prostate remains healthy.
That's a lot to keep track of.
It is. For a doctor who has exactly 15 minutes to see a patient, managing all of that is daunting.
I can appreciate the logistics of that, for sure. But the sources also dive into the less legitimate concerns holding doctors back. And this is where the biological mechanisms get really interesting.
Well, absolutely.
Because a huge part of the problem stems from outdated medical school training regarding why men have low testosterone in the first place, right?
Yes, and this is a critical distinction to make. Many older clinicians were taught that hypogonadism, which is the medical term for low testosterone, is a rare condition known as primary hypogonadism,
Primary meaning what?
meaning the testicles themselves are physically broken or failing. It's a localized hardware issue.
But that completely misses what's actually happening to most guys today, doesn't it?
Entirely. What those older textbooks miss is the massive modern rise of secondary hypogonadism.
Okay, so a software issue.
Exactly, a software issue.
Yeah.
The testicles work fine, but the brain, specifically the hypothalamus and the pituitary gland, it just stops sending the signal to produce testosterone.
Huh.
And the number one driver of secondary hypogonadism today is obesity and metabolic syndrome.
Right. Just to be totally clear on the biological stakes here, can you define metabolic syndrome for the listener?
Sure. So metabolic syndrome is a cluster of conditions happening together. It includes increased blood pressure, high blood sugar, excess body fat around the waist, and abnormal cholesterol levels.
Sounds like a recipe for disaster.
It is. It significantly increases your risk of heart disease, stroke, and type 2 diabetes. And it wreaks absolute havoc on testosterone production.
Which leads to what the source calls the just lose weight reflex. Like a guy comes into the clinic, he's overweight, his testosterone is tanked, and the doctor just says, hey, eat less, move more.
Right.
But there's a biological catch-22 here, isn't there?
A massive one. Because having chronically low testosterone makes losing weight incredibly difficult. You lose muscle mass and your metabolic rate drops.
So you're just stuck.
But the real mechanism, like the real aha moment here, has to do with fat tissue itself. Fat tissue is not just inert baggage that you carry around. It is an active endocrine organ.
Wait, really? Fat acts like an organ?
Yes. It contains an enzyme called aromatase. And aromatase acts like a chemical refinery that literally converts a man's remaining testosterone into estrogen.
Wow. So the heavier you get, the more aromatase you have, which means your body is actively stealing what little testosterone you have left and turning it into estrogen.
Precisely. Which then tells your brain you have plenty of hormones, so the brain shuts down natural testosterone production even further.
Man, that is a vicious cycle.
It's a highly self-perpetuating cycle. But because of defensive medicine and a fear of aggressive anti-aging clinics, mainstream doctors often refuse to intervene with TRT to break that cycle.
Which perfectly sets up the collateral damage of all this hesitancy. If a doctor refuses to fix the root hormonal void, they still have a patient sitting in front of them complaining of feeling terrible.
Right, they have to do something.
Exactly. Here's where it gets really interesting. And frankly, it sounds like a cascading failure of modern medicine. Let's walk through the reality of the polypharmacy trap.
It really is a profound failure to understand the interconnectedness of the human body. Let's look at the theoretical patient from our sources.
Okay, lay it out for us.
So he's a 45-year-old guy. He used to be active, but now he is exhausted, he's gaining weight, his drive is gone, and his lab work shows clinically low testosterone. But his doctor, shaped by that 2013 scare and a fear of the monitoring burden, won't treat the hormone deficiency.
So instead of fixing the root cause, they start playing whack-a-mole with the symptoms. The guy says he has no motivation and feels bleak, so the doctor prescribes an SSRI.
Right, a selective serotonin reuptake inhibitor, which is commonly used to treat depression. But then they check his blood work, and he has high cholesterol, specifically low HDL. So the doctor adds a statin to his chart.
And his blood sugar is creeping up into pre-diabetic territory because of the weight gain.
So he gets a prescription for metformin. Metformin is a drug that lowers blood sugar levels by improving how the body handles insulin.
Okay, but his blood pressure is also too high.
So the doctor prescribes an ACE inhibitor, which relaxes the blood vessels to lower blood pressure.
And now, because his hormones are completely out of balance, He's dealing with erectile dysfunction.
He walks out with a prescription for Viagra.
He's stressed, his body's entirely out of rhythm, so he can't sleep at night.
Sleeping pills are added to the list.
Now he's having anxiety attacks about all these new health problems.
And he walks out with a second SSRI, or maybe a benzodiazepine for the anxiety.
That is up to 8 different medications. It's like trying to fix a dead car battery by replacing the radio, the headlights, the windshield wipers, and the spark plugs just because none of them will turn on.
Yeah.
I mean, you are spending a fortune swapping out parts, entirely ignoring the fact that the primary power source is completely drained.
That is a phenomenal analogy, but I'm actually going to make it even darker.
Uh-oh.
Because in this medical scenario, replacing the radio and the headlights is actually draining the battery even faster.
Wait, how is that mathematically possible?
This is the biological kicker. Several of those medications he just got prescribed have mechanisms that actively worsen testosterone levels.
You're kidding!
No, take the statin, for example. Statins are incredibly effective at blocking cholesterol production in the liver. But cholesterol is the fundamental chemical building block the body uses to synthesize testosterone.
Oh, wow.
It's the raw material. If you artificially suppress cholesterol too much, you are starving the body of the exact material it needs to make the hormone.
So the drug given to fix the symptom caused by low testosterone physically prevents you from making more testosterone.
Yes, it's completely counterproductive. And the SSRIs are often just as bad. They alter neurotransmitters in the brain, which can increase a hormone called prolactin and decrease dopamine.
Which does what?
Well, that combination can chemically obliterate a man's libido and further suppress natural testosterone production. You end up creating a biological downward spiral that requires even more pharmaceutical intervention.
But there is a shift happening, right? Our sources mention functional medicine and progressive endocrinology.
Yes, that 20 to 30-year clinical lag we discussed earlier is finally starting to close for some practitioners. The newer wave of medical thinking recognizes that addressing the root hormonal deficiency can resolve multiple metabolic issues simultaneously.
That makes so much more sense.
Right. By restoring testosterone to healthy natural levels, the patient has the energy to exercise, they preserve muscle mass, their insulin sensitivity improves, and the brain fog lifts.
Meaning, you fix the car battery and suddenly the radio and the headlights turn back on and you can just throw all those extra replacement parts away.
Often, yes. Patients can sometimes reduce or entirely eliminate those other medications. Now, we have to be absolutely clear here. TRT is not a magic cure-all.
Sure.
It doesn't instantly vaporize poor diet choices or cure unrelated diseases. But for the right patient with confirmed hypogonadism, replacing that missing hormone is profoundly transformative.
Okay, but if treating the root cause is this effective and it literally gets people off of half a dozen other prescription drugs, why is it still treated like a dirty word in polite society?
That's the big question.
Why do guys whisper about it? And the answer in our sources is wild because it has nothing to do with medical journals. It's buried completely in pop culture, specifically the 1980s. So what does this all mean? How did a hormone become a cultural boogeyman?
To understand this, we have to look back at the steroid scandal era of the 1980s and 90s because it completely dictated the public conversation. It wasn't just a sports issue. It became a full-blown moral panic.
I mean, the cultural touchstones of that era were everywhere. You had Ben Johnson famously getting stripped of his gold medal at the 1988 Olympics. But the sources point out it was much darker than just cheating at sports.
It was much darker. You had Lyle Alzado, the ferocious NFL defensive lineman who developed a rare brain lymphoma. Before he died in 1992, he went on national television, gaunt and frail, and blamed his terminal cancer entirely on his decades of massive steroid abuse.
Man, I remember seeing clips of that.
Yeah. Now, medically speaking, there's no rigorous scientific link establishing that his specific steroids caused his specific brain tumor.
But the truth didn't matter because the image of this invincible NFL giant dying on camera and blaming steroids was just burned into the American psyche.
Exactly. And the media simultaneously began a relentless campaign around roid rage. The narrative was that testosterone doesn't just make you muscular, it makes you psychotic, violent, and dangerous.
Just totally out of control.
Right. Then you roll right into Mark McGuire and the baseball steroid era, and later the Balefo scandal. The media hammered home a single, unified narrative for decades. They said testosterone is not a human hormone. It is a dangerous, illicit street drug used by cheaters and criminals.
And that media hysteria didn't just stay on the television. It literally changed federal law.
It did. The public pressure was so intense that lawmakers felt compelled to act. The Anabolic Steroids Control Act of 1990 formally made testosterone a Schedule III controlled substance in the United States.
Let me just repeat the hook from the beginning of this deep dive so it really sinks in. A hormone that the male body naturally produces to regulate its own metabolism, bone density, and mental health was put in the exact same legal and criminal category as ketamine, LSD precursors, and codeine.
Yes, and that legal framing completely obliterated the medical distinction between abuse and treatment. In the eyes of the law, and therefore in the eyes of the public, they were the exact same thing.
But the sources highlight the biological math here. And the gap between abuse and treatment isn't just a fine line, it's a completely different universe, right? Let's break down the actual numbers.
The gap is astronomical. When we talk about the abuse seen in elite powerlifters and bodybuilders from that era, we are talking about supraphysiological doses.
Supra meaning what?
Meaning way, way above what the human body could ever naturally produce. An abuser might be taking 1,000, 2,000, sometimes 3,000 milligrams of synthetic testosterone a week, purely to force unnatural muscle growth.
Which naturally leads to massive side effects.
Massive side effects. Severe liver strain, cardiovascular hypertrophy, which is the dangerous thickening of the heart muscle, and severe psychological mood swings.
Right.
But medical treatment, TRT, is about physiological doses. We're talking about 100 to 150 milligrams a week. That is literally just enough to restore the body back to its normal baseline level.
That's a huge difference.
A healthy 25-year-old male produces that much naturally. It's the same molecule, but one is a flood that destroys a town, and the other is a glass of water for a man dying of thirst.
I love that analogy. But because of that 1980s stigma, the guy sitting in the doctor's office feeling exhausted and depressed doesn't want to ask for the glass of water. He's suffering in silence because he's ashamed.
Yeah, unfortunately.
He thinks if he asks his doctor to check his testosterone, the doctor's going to look at him and assume he's trying to cheat at a bodybuilding show.
If we connect this to the bigger picture, we have to recognize how deep this conditioning goes for all of us. Even today, every time a modern athlete or an Olympic sprinter gets caught doping, that decades-old stigma is instantly reinforced in the news cycle.
Right. Everyone talks about it again.
The headlines flare up, the association with cheating and danger is renewed, and the everyday man who just needs his baseline health restored is the collateral damage.
Which brings us to the most incredible irony in this entire deep dive.
Oh, this part is amazing.
If we're talking about the 1980s cultural stigma and the fear of grotesque bodybuilders, we have to talk about the absolute poster boy of that entire era, Arnold Schwarzenegger.
It really is the ultimate paradox of this whole conversation. Arnold is the undisputed face of the golden era of bodybuilding, but the historical reality of his actual chemical usage is shocking to most modern observers.
Our sources pull the curtain back on this, and it honestly blew my mind. Arnold has been very open about his steroid use in the 1970s, and by modern standards, it wasn't a flood at all.
It was extremely modest.
Yeah.
He has stated that his regimen consisted of about 15 milligrams of Dianabol a day. Dianabol is an oral anabolic steroid, and he paired that with one injection of primobolan, a mild injectable steroid, once a week.
Wait, I need you to contextualize this for us. How does Arnold's Mr. Olympia protocol compare to what we've been talking about today?
This raises an important question, because the math is jarring. Arnold's regimen is roughly equivalent to the total androgen load that a modern TRT patient, perhaps on the higher end of the therapeutic scale, might use today just to optimize their health and feel normal.
Wait. You're saying the regimen that built the Terminator is basically what a progressive functional medicine clinic might prescribe to a 50-year-old accountant today, so he has the energy to play with his kids?
Exactly. The total dosage is remarkably similar.
So if Arnold's doses were actually that low, where did the stigma of the grotesque, disfigured bodybuilder come from? Because when people think of steroids, they think of the guys with the massive distended guts, the mass monsters.
Those physiques didn't appear until the late 1980s, the 90s, and the 2000s. That's when the culture of bodybuilding shifted, and competitors started using those multi-gram supraphysiological weekly cycles we talked about.
Oh, I see.
And they weren't just using testosterone. They were stacking it with massive amounts of synthetic growth hormone and insulin, which literally makes the internal organs grow, pushing the stomach outward.
Hence the distended guts.
Right. And eventually it led to the use of synthol.
What's that?
Synthol isn't even a hormone, it's a site enhancement oil. Bodybuilders literally inject the oil directly into the muscle tissue to artificially inflate it like a water balloon. It destroys the muscle, but it makes the arm look 24 inches around.
Good grief. So Arnold's physique, the specific body that started this whole cultural phenomenon and subsequent panic, came mostly from top-tier 1 in a billion genetics and insane, grueling discipline in the gym. The hormones were just playing a very minor supporting role.
Precisely. If a doctor blindly looked at a chart containing Arnold's 1970s protocol today and prescribed it to a severely hypogonadal patient, it would be considered a relatively reasonable, albeit aggressive, medical intervention. But the cultural framing is completely disconnected from that medical reality.
It's exactly like refusing to acknowledge that having a single glass of wine with dinner is a normal, historically common thing to do, simply because you know that rock-bottom liver-failing alcoholism exists.
That's a great way to put it.
You can't base your entire medical framework for wine on the absolute worst-case scenario of abuse. But that is exactly what we've done with TR2.
That's a perfect synthesis. We've allowed the extreme multi-drug abuse of the late 90s mass monsters to dictate the standard of care for a basic, fundamental hormone deficiency today.
So let's bring this all together. We've navigated a pretty wild landscape today. We started with the very real clinical hesitations doctors who were spooked by the flawed, debunked cardiovascular data of 2013, or who are completely overwhelmed by the intense monitoring requirements of hematocrit and estrogen.
Which, combined with outdated training that ignores how belly fat actively converts testosterone into estrogen, forces patients right into that polypharmacy trap.
Right, the guy walking out with an SSRI, a statin, and blood pressure meds that act like bad replacement parts, draining a dead car battery even faster.
All of which stems from a cultural shame born in the 1980s. A media-driven stigma so strong it literally made a natural human hormone, a Schedule III controlled substance, even though the poster boy of that era, Arnold Schwarzenegger, was using doses that closely mirror modern therapeutic care.
And this is exactly why you listening right now need to care about this, even if you never need TRT, even if you are just fascinated by how information evolves or completely fails to evolve,
Yeah.
because this deep dive proves a crucial point about modern health. You have to be your own advocate. You have to understand the mechanisms of your own body because standard medical practice can, and often does, lag decades behind the actual data.
It's a stark reminder that doctors are human. They are susceptible to the exact same media narratives, fears, and cultural biases as the rest of us.
Exactly. So I want to leave you with a broader thought to mull over, something to explore on your own. We've seen how a 30-year-old cultural panic about athletes and bodybuilders successfully derailed the standard of medical care for a fundamental human hormone. So what other widespread medical treatments or lack thereof are currently being driven by pop culture stigma rather than actual rigorous science? Are there other physiological dead batteries out there that we're just ignoring because society told us it was taboo to look under the hood?